should move to our last session, which is a panel discussion. So for that, may I request Dr. Shondeep Ganguly sir and Dr. Shantanu Acharya sir to come over to the stage to chair the session. I'd request you to introduce our moderator and the panelists for the next session. So this is our last session, and hopefully it will be an interactive and engaging session.
So, good evening. Thank you, Animesh, for conducting the wonderful conference on GU cancers, controversies to consensus. So, the last session will be the sequencing systemic therapy in metastatic prostate cancer. I will request Dr. Ghansham Biswas sir, Senior Medical Oncologist from Bhubaneswar, to moderate the session. And you will call the panelists or I will? And I would request the panelists, Dr. Shaptoshi Ghosh, Clinical Oncologist from Hope and Hill Cancer Hospital, Shiliguri, Dr. Shayan Pal, Radiation Oncologist from Apollo Cancer Hospital, Kolkata, Dr. Jibak Bhattacharya, Radiation Oncologist, Apollo Cancer Hospital, Kolkata, Dr. Shondeep Sarkar, Radiation Oncologist, Ruby Cancer Hospital, Kolkata, Dr. Tanmay Ghosh sir, Radiation Oncologist, Dr. Ashish Upadhyay, Medical Oncologist from Kolkata, Dr. Saurabh Guho, Clinical Oncologist, Dr. Amitabh Ray, Radiation Oncologist from CNCI, Dr. Ashutosh Daga, Medical Oncologist from AMRI, and Dr. Tanmay Mandal, Medical Oncologist from AMRI.
May I request Dr. Shombit Mohanty, Dr. Siti Das, and Dr. Saurabh Mishra to also join the session, if you don't mind.
So score 3 out of 10 now. So last man in, and so one line, so no sequencing as of now. So thank you organizers and thank you chairperson. So I should not be the hold you keep. So prostate cancer disease progression. So 5 to 25% of new prostate cancer diagnosis will present as a de novo castration sensitive prostate cancer, and 10 to 20% of men diagnosed with prostate cancer develops CRPC within approximately 5 years of follow-up. And today we'll see the more importance is given to a non-metastatic CRPC. So I'll start from Tanmay. So out of 100 prostate cancer patients, you treat how many patients fall into roughly metastatic CSPC, non-metastatic CRPC, and metastatic CRPC?
So out of 100 prostate cancer patients, around metastatic castrate-sensitive prostate cancer will be on de novo CSPC. It will be around 40% of the patients. So non-metastatic CRPC will be around another 30 to 40%, and the metastatic CRPC will be around 30 to 40%.
Okay. So Dr. Ashish, so do you think non-metastatic CRPC, which was probably getting ignored into clinical practice, has gained importance?
Yes, sir, definitely. Actually, non-metastatic CRPC has always been very dicey, because whatever we have used, it's all because of the conventional imaging. And the conventional imaging, if we use PET scan instead of conventional imaging, then mostly there will be stage migration. So it's very dicey.
Sthiti, so what are the common comorbidities associated with prostate cancers?
As most commonly they are seen in old age, so we can expect diabetes and also benign hypertrophy of the prostate along with prostate carcinoma, diabetes, hypertension.
So Tanmay, So this is one of those data on file. So do you think cardiovascular incidences are also more? So either presenting with any cardiovascular abnormality or during the treatment the patient develops some of these abnormalities?
So the patients, as these are mostly are elderly patients, so they generally present with hypertension or ischemic heart disease in most of the patients what we see. And on treatment, cardiovascular comorbidity, development of a new onset ischemic heart disease or a new onset heart failure, that is not very commonly what we see. But
Right,
yes,
right, absolutely.
they generally present de novo with a
Since most of you are used now for more than a decade with abiraterone, and we know that some amount of steroids are to be given, so this paper also showed that worsening of diabetes, because India being a hub of diabetic and Odisha is hosting the diabetic national conference, is ongoing now. So 88% worsening of diabetes with long-term steroids. So now coming to a metastatic castration-sensitive prostate cancer. So there are three group of drugs. We know that GnRH analogs and GnRH antagonist, and very soon in February we'll have the oral antagonist, the generic is available. And the major group is AR antagonist. So almost first generation AR antagonist we are using as flare prevention. Otherwise, these are not of much use today. Otherwise, we have been into the second generation AR antagonist, and the other group are CYP inhibitors like ketoconazole and abiraterone. So what is your preferred first-line treatment option for a metastatic CSPC and why? So ADT plus any of this, Saurabh.
So if we are talking about doublet only, so out of the 4 drugs, usually I would choose all these drugs for the appropriate patient. That means if someone is a 60 years old, 50 years old, absolutely fit patient, I would like to give him chemotherapy, ADT with that. Someone is of course, high volume disease. And if someone is not very fit, bit elderly, and still high risk, high volume or low volume, any of these 3 agents would be used.
Right, so we have seen since morning, so beautiful talk and debates. So Charted and Stampede showed the utility of docetaxel, and then came Latitude and Stampede again. So came the era of abiraterone, the first one in the oral anti-androgen. Then came enzalutamide from Enzamet. Then Arches showed again enzalutamide, Titan now apalutamide. So how did you choose? So how did I put it? Because before 2001, before the triplet came into picture, so docetaxel versus abiraterone, so Ashutosh.
So basically, depends on the bulk of the disease, the rapidity which we want to decrease the symptom of the patient, and also the performance status of the patient.
Right, so these are certain things. So rightly said, sir, the high volume disease versus low volume disease, and definitely the toxicity and the treatment duration. So because from those charted, we found out that 6 cycles of, so like in CLL, we talk about finite treatment or infinite treatment. So this was basically, if chemotherapy, then 6 cycles, if abiraterone, then continue till progressions. So this is one of the papers, so which I was also an author, again facilitated by Glenmark. So sequence of systemic therapy, so this was again 3 years back. So sequencing of systemic therapy in the management of advanced prostate cancer in India, a Delphi-based consensus, so from north, east, south. So again, so it was basically ADT plus docetaxel, so it was a prior triplet, so preferred in a high volume disease, and ADT plus abiraterone again preferred in a low volume disease. So these were clinical statement with consensus and near consensus. So what are the challenges with abiraterone plus prednisolone in metastatic CSPC patients? Tanmay.
So the main challenge is diabetes. Pre-existing diabetes, if anyone has, that's the most important challenge what we face.
Any other toxicities? Just enumerate.
So other than that, mostly with abiraterone, transaminases, hypertension, these are the certain other toxicities, but we don't get that much amount of these side effects, the amount of sugar elevation what we see.
I had 2 patients with hypokalemia. This was a refractory hypokalemia. So potassiums never went up more than 2. So hyperkalemia, as you rightly said, elevations of liver enzymes, hypertension, and some probably increased incidence of cardiac disorders. Frequent monitor for serum electrolytes is needed. Low dose of prednisolone can worsen diabetes, hypertension, as the paper showed. And probably the long-term use of steroids, we don't know so how harm they're going to do it. So with all the now the second generation drugs that are available, so enzalutamide, apalutamide, and darolutamide, so after abiraterone, so what are the common toxicities, Saurabh?
So enzalutamide is in elderly patient seizures, precipitation of seizures is something which we are worried about. Apalutamide and all pretty well tolerated, not that much of toxicity, some liver toxicities.
Ashish, have you seen rash and hypothyroid? Because now 6 months or so, the apalutamide generics are available. Have you seen?
No, sir, I haven't seen, but these all are documented side effects, along with the CNS side effect which apalutamide causes.
So beside these side effects, if you go into those 3 drugs that are available, so there is something called a skeletal related pain events. So prevent pain progression, so is much better with darolutamide as compared to enzalutamide and apalutamide. So these are all side effects or clinical factors. So when you have all level of evidences are same, then how do you choose one over the other? So factors to consider before selecting any novel hormonal agents. Or
So with abiraterone, of course, we are going to use steroids. That would be an important factor. With enzalutamide, apalutamide, we won't use. And other factors to consider is that we have data for apalutamide that if there is a rapid decrease in serum PSA, these patients are likely to do good. Someone who has a seizure, of course, you'd like to avoid enzalutamide. So these are some of the factors which we could use.
so these are systemic therapy for. So how frequently do you monitor PSA level during the treatment of metastatic CSPC patients? I didn't get his name.
So at least 3 months, 3 to 6 months, we should monitor for patients undergoing treatment.
Okay, and so do you monitor the quantum of PSA decline? PSA more than
Obviously.
50 or PSA more than 90%?
Obviously, the velocity of decline is also important. You should also monitor that.
So we have
PSA
started
decline.
doing that because I never did that in the practice, but probably after the apalutamide studies came into picture, so that showed how different this molecule is as compared to enzalutamide and abiraterone. Because, so why it is important? Because effects of PSA reduction on clinical outcome. So you are looking at a radiographic progression-free survival, overall survival. The most important is how much you are delaying this patient hormone sensitive to a castration resistance. So apalutamide versus enzalutamide in regards to that PSA 90, 3.1 months for apalutamide versus 5.2 in the enzalutamide. So now Tanmay, so since even in the last panel you were discussing about triplet. So have you started using triplet in all patients or you will reserve it for some patients?
So we have used docetaxel abiraterone with prednisolone in a couple of patients, and as I said, the fittest of them, because that is what we have. And of course, synchronous metastasis, upfront presenting with metastatic castrate rather than metachronous. That is where we have used this combination.
Ashish?
I've also started using the patient is fit enough, then mostly I prefer triplet.
So the Arasens, because darolutamide is a costly drug, I don't know how many I have used in a clinical trial setting. So piece 1, so we have both have the OS matured now. Enzamet was a negative trial. So in regards to triplet, out of these 3, so Enzamet was a negative, otherwise Arasens and piece 1 has shown an OS benefit. So there is a paradigm shift from ADT plus docetaxel, then ADT plus anti-androgen, and now ADT plus docetaxel plus either abiraterone or darolutamide. So that's the new trend. So the rationale being more favorable disease biology, less acquired resistance. So since most of these patients haven't received any treatment, so likely that the patient will have less toxicity, and that's why even in the trial, so the toxicity, in spite of triplet, there was toxicity not much. So this was piece 1. So the radiographic PFS and the OS benefit was there. In the Arasens, again, it has shown an OS benefit. So the piece 1 had achieved an OS benefit and also the Arasens. So this was a triplet versus doublet updated network meta-analysis. So that shows that ADT alone no longer represents a valid treatment options for metastatic HSPC. Similar considerations apply to doublet therapy, docetaxel and ADT. For low volume metastatic CSPC in comparison to ADT, the benefit of combination therapies other than ARPI plus ADT was not substantial. So from the meta-analysis, it showed that for a high volume disease, so dialutamide plus docetaxel plus ADT ranked first, followed by abiraterone plus docetaxel plus ADT. So Tanmay now, so this is another paper. This was last year ASCO Genitourinary. So then there was a bifurcation or the post-hoc analysis of the piece 1. So less than 70 versus more than 70. So any comments?
So sir, more than 70, most of the time it becomes difficult for docetaxel to be used also because of the comorbidities which they have. Tolerance becomes an issue. So yes, I would prefer less than 70 as the age limit for which the triplet therapy is much more beneficial.
Right, so that was also the post-hoc analysis. More than 70 years derived a lower benefit, both in terms of the primary endpoints was radiography, PFS and OS as compared to less than 70 years. So putting the evidence into a real world, so how do you choose now? So if age is not a barrier, so the volume of disease, the risk category, the presence of visceral disease, histological and molecular risk factors. So Sambit, are you there? So at histological and molecular risk factors, are you going to treat differently with, not with the targeted therapies, but at least at the systemic therapies that are available today?
I mean, histologically, there are certain things we definitely look into when we have in the metastatic setting. One is whether there is a neuroendocrine phenotype. That is one thing. Then if you see a lot of intraductal carcinoma component, that means the tumor is spreading through the prostatic duct.
So what will be the answer to this? Any validated predictive molecular biomarkers?
I mean, if I see a lot of intraductal histology, I would talk to my urologist and advise for a HRR testing. And if there is, I mean, AR receptor, IHC was there in the previous years, but it's not very validated. It doesn't really go hand in hand.
So Ashish, so whether all 3 drugs, so you have decided that you want to give a triplet because looking at the benefit. So whether all 3 drugs need to be given concurrently?
So for synchronous meds, definitely. For meta-chronous meds, yes, we can consider.
Right. So it also remains unclear whether all 3 drugs need to be given concurrently or if ARPI can be started before or after docetaxel. The questions which was asked to Dr. Sambit, any validated predictive molecular biomarkers? So currently validated predictive biomarkers remains lacking in clinical practice. So as Ashish said, so this is the proposed selection of algorithm for high volume synchronous, low volume synchronous, high volume metachronous and low volume metachronous. So this is our friend in need, NCCN. So CRPC, so there can be a group no prior docetaxel or no prior anti-androgens like novel hormonal agents. So Sambit, what are the molecular pathways involved in the development of a CRPC?
For the metastatic CRPCs are in castrate resistant. So basically the tumor is is developing androgen insensitivity or resistance, either because of downregulation of the receptors or there is upregulation of aurora kinase and this thing, RB loss, retinoblastoma gene, which we know is a tumor suppressor gene. If it is lost or aurora kinase is amplified, those are main 2 pathways in the development and androgen receptor insensitivity or resistance. So in those settings, I mean, suppose we get a biopsy, suppose we are getting a biopsy from a metastatic site. So as a pathologist, we basically have to look for 4 things, whether we have the prostate cancer, the same tumor is there, or the tumor has transdifferentiated into a neuroendocrine phenotype, or there is a second malignancy, and if we have tissue left, whether we can go for HRR testing, like a homologous recombination repair testing.
So Tanmay, now since we are talking about CRPC, the basket or the armamentarium is full now. So why we need sequencing and how you decide on what to use and what not to use?
So why we need sequencing is to get the maximal overall survival benefit. That is the reason we need sequencing. And how do you decide? Yes, it's mostly decided on the HSPC setup. Means if it's prior use of docetaxel is there, then in the second line, and if the patient is fit, cabazitaxel might be an option, enzalutamide might be an option. So mainly the decision is made based on the prior treatment which we see, which we do, along with that other factors like the performance status, the comorbidities, the disease volume in the present scenario, means in the CRPC setup, if the disease load is too high. So these are the other factors which we also see during decision regarding treatment planning in the CRPC setting.
So now, so you have used suppose an abiraterone. The patient has done well for 24 months. So would you use, so on progression, so another in the second generation?
So you mean after,
Now this is CRPC setting.
so after in CRPC we have already used second generation anti-androgen, and then we should, I mean, it depends upon the volume of progression. If it is a high volume, then we may add a, like Dr. Tanmay just said, that if we have not used docetaxel, we may use a docetaxel. If we have used docetaxel, we may use cabazitaxel. And if it is a low volume progression, then we may
But
add
in practice, you have seen a patient, 73 years, either fit, patient was doing well for 28 months, and suddenly you say the disease has progressed and you need now docetaxel. So out of 10 patients, so all the 10 patients will agree for docetaxel? You may not have evidence for that, but you still try with any of these hormonal agents.
Yeah.
But because that is easy to weigh, so lack of evidence doesn't mean, so you cannot offer that. But there are patients, definitely. Yes, Saurav?
So that is what we were also discussing today. So post ARPIs, another ARPI getting a response difficult. Docetaxel giving the patient is difficult. Therefore, this PSMA4 study could be one good option.
So a decade back, the same story happened with RCC. So we started with sunitinib. So if the patient has done well for 2 years, so should we go for anti-VEGF or should we go for mTOR inhibitors? And there was two schools of thought. So either way, patients had benefited.
We have the option of also now olaparib along with that. That pathway is also there, right?
So right. So from one oral drug to the other, from anti-androgen to a chemotherapy, from docetaxel to a chemotherapy again. So why? Because there are patients who doesn't want to pay money from their pocket, so insurance patient, and where we know these oral drugs are probably not get covered. So बोलते आप जो दे रहे हैं दो, I don't want to pay a single penny. The patient from docetaxel moves into a cabazitaxel. The patient might not have received any anti-androgens. So like castration sensitive, so we have discussed this. So progressive disease within 12 months, then what are the options? Then progressive disease more than 12 months. So somebody has progressed on abiraterone, somebody has progressed on all these orals. So coming to a fifth situation, so which we will see in future, because since non-metastatic CRPC is getting importance and all 3 drugs are approved, so there will be a patients where we'll see this patient into a metastatic disease. I'll not touch upon this. So guideline summary, no clear sequencing recommended that has been provided. So what the guidelines do not tell us, so which drug for which patients, options, but no specifications, no comparative data. So what is the best sequence, when to stop a drug therapy? So Ashish, now, so somebody has been doing well. Somebody wants to have a honeymoon period, so no drug holiday. Have you done that?
Sir, in metastatic setting, if the patient is, the quality of life of the patient is deteriorating, then we can consider. However, for ADT, the evidence is the opposite. We cannot stop because intermittent ADT is not helpful in metastatic settings.
Right. So this is first case, case 1. So he is 73 years male, comorbidities under control. So metastatic CSPC, SNR adenocarcinoma, Gleason score of 5+4, symptomatic skeletal mets, baseline PSA of 168, and so he had a coronary artery disease, hypertension, hypothyroid, and this cardiac episode was just 6 months prior to this diagnosis of cancer. And monthly antagonist, since his blood sugars were labile, and so I started him on low dose of abiraterone with prednisolone. So now, so he had some family history, and this is the HRR report of this patient. So we picked up CDK12 in exon 1 and exon 2. So Sambit. So both are frame shift, and you can see of, so allelic burden of 11% and 74%. These are pathogenic.
And that initial process, that means the tumor suppression effect is gone. So that is
So
basically
this is at baseline.
this is at the baseline. So it is sensitive. So it has the defect at the baseline level. The patient has a family history.
Yes.
Family history of what cancer?
Family history of prostate cancer.
Prostate cancer. So probably that is because there is, what is the values you said is more than 50%, 70% or something?
Yeah, one is 11% in the exon 1, and exon 2 is 74%.
So when it is 74% means more, the variant allelic frequency is more than 50%. That means it's a homozygous, and there must be a genomic, this is an indirect evidence of, it is in the genomic, the germline mutation rather than a
Saurabh, as
somatic.
a physician, a medical oncologist, so does it signal something, and do you want to do something now?
So that's what I was telling, he was telling. So if VF is high, germline we can do, but then with this mutation, I do not know if it's a driver mutation or just a passenger mutation.
It is a frame shift deletion. The frame shift deletions with a 70% VAF are drivers.
So Tanmay, Ashish, anybody, so anything that brings out something from this?
So CDK12 mutation, basically they don't respond to PARP inhibitors or novel agents. That is what is shown in profound trial also. In the cohort of CDK12, the hazard ratio was around 0.35, while overall it was 0.75. So we have different, it's said that immunotherapy can work in these subset patients. 10 to 33%, even CDK4/6 inhibitors are being investigated.
Right. So what happened? So post 6, sir.
Sir, we will finish within 5 minutes.
Yeah, so in 4 minutes I'll finish this. So post 6 months, so PSA started increasing. So he was on antagonist. So testosterone is less than 40, PSMA done at this point of time, so new lesions in the bones. So what, Sthiti, as a radiation oncologist, anything?
I think first I'll ask why in the first scenario the radiation was given or not, because there were
radiation was
symptomatic
not
skeletal mets.
Not
So,
given.
so since there are symptomatic mets, we should offer
So
radiotherapy.
this patient has come from Apollo only. Is he your
And
patient?
especially we should use SBRT in these cases because it gives rapid symptomatic relief
Multiple
and
bone mets. Multiple.
multiple,
Extensive bone.
extensive.
High
Extensive, then we have to see the number of lesions and the aggressive lesions we have to treat. We cannot treat all the lesions, but at least 3 to 4 lesions.
So now you have not treated. Now this patient is symptomatic now. So he was doing good. So now evaluation clinically. So he has started again, clinical symptoms have come back. So although CDK12 mutations were initially reported as mutually exclusive with alteration in HR genes in both ovarian cancer and prostate cancer, CDK12 inactivation was neither associated with lower expression of HR genes, nor was it associated with the ploidy changes or mutational signatures typical of HR deficiency in these type of tumors. So are CDK12 mutation associated with aggressive prostate cancer? Is CDK12 mutated MCRPC is a biomarker for immunotherapy? I think Ashish touched upon that. I've just put a clipping here. CDK12 altered MCRPC have a worse prognosis, so this seems to be an aggressive disease, and this our patient actually happened in that way only. With these tumors surprisingly being primarily enriched for CD4 FOXP3 cells that seems to associate with worse outcome and maybe immunosuppressive. So I've started this patient, though there are evidences now with enzalutamide and olaparib, And so I've started this patient on abiraterone because he's a CAS patient. So he was continued on low dose abiraterone with olaparib. So I put this patient on denosumab trial, and now he has received palliative radiotherapy. So metastatic CRP, so this is a second case, metastatic CRPC, hypertension, diabetic, SNR adenocarcinoma, GS, Gleason score 5+4, biota orchidectomy done, exposed to abiraterone, docetaxel, enzalutamide, cabazitaxel, and zoledronic acid, symptomatic skeletal mets with visceral crisis with hepatic derangements. Elder brother also died of carcinoma prostate. So this was the test done. You can see ATM and BRCA2 positive with 58.8 and 27.2. Sambit?
Yeah, this has definite ATM. Again, the response of isolated ATM to PARP inhibitor is also not that great like BRCA deficient.
So any takers for rucaparib, olaparib, Ashish, Tanmay?
Sorry, the patient is in visual crisis, so I would go for platinum-based chemotherapy. And if the patient responds, maybe then I'll start PARP inhibitor.
Right. So before, again, we could decide, actually the patient succumbed. So new strategies. So since 2022, we are talking about PARP inhibitors. We have heard about talk on Dr. Naveen AKT inhibitors. So Propel and Magnitude combining PARP inhibitors with anti-androgens. And in this morning, we have also heard about PSMA, lutetium, immunotherapy. So, Saurabh, so we have seen from Naveen's slide also. So these, unlike many other cancers, so the incidence of MSI high or a TMB high is much less. And the response you see among all the solid tumors in prostate cancer, the response rates are just double figures.
So probably we may have to go for something on, so pembrolizumab of course in MSI high, now we have data with cabozantinib with another molecular immunotherapy, so which is coming.
So thank you so much. So the key takeaways is a heterogeneous disease, multiple alternatives, different strategies, directed therapies, and new biomarkers are to be searched. How to select treatments, what is the best sequence yet to be known. We need to work as a team for our patients. Thank you, ladies and gentlemen. So thank you for this opportunity.
Thank you, sir. Thank you for the nice and excellent moderation. Thank you, our panelists. Before we conclude the session, may I request our chairperson, Shantanu sir, to hand over a memento to Dr. Ghanshyam Biswas as a token of appreciation. Sir, please come forward. And after that, we'll have a group photo with the panelists. Sir, please come forward. And we'll now have a group photo with all the panelists.